Good afternoon. I call this hearing to order. A quorum is present. Without objection, the chair is authorized to declare a recess at any time. Before we proceed, I would like to go over a few housekeeping items for our hybrid hearing. First, if you are experiencing connectivity issues, please make sure you or your staff contact our designated technical support so those issues can be resolved immediately. Members and witnesses participating remotely must continue to use the video function for the duration of their participation in the hearing unless they experience connectivity issues or other technical problems that render the member unable to fully participate on camera. It is committee and subcommittee policy that members will remain muted when not recognized, just like turning your microphone on and off during an in-person hearing. This is out of courtesy to all members on the committee, and so that background noise does not interfere with another member who is recognized to speak. When you are recognized, you will need to unmute your microphone and pause for a couple of seconds before speaking so that we will be able to hear everything you say. In order to ensure everything members say is captured on the live stream of this hearing, I ask that members pause for 2 to 3 seconds before beginning to speak. If you wish to have a document inserted into the record, please ask for unanimous consent and have your staff email the document to veteranaffairs.hearings@mail.house.gov. It will be uploaded to the committee document repository. Without objection, members will be recognized in order of the subcommittee seniority for questioning witnesses today. This will make it easier for me to ensure all members participating have an opportunity to be recognized. I ask for unanimous consent that Representative Newhouse from the Washington delegation be permitted to join us today, or join today's hearing to speak to his concerns about the program, should he be available without objection so ordered. Does any member have a question about the procedures for this hearing? Hearing none, we shall proceed. I now recognize myself for an opening statement. Good afternoon, and thank you for joining us. We continue this subcommittee's oversight of the Electronic Health Record Modernization Program. We are now 4 years into a 10-year contract. VA has deployed the full system at 2 medical centers and the scheduling solution to a third. While I believe that the majority of the system is working as advertised, there are some very real concerns with parts of it, namely the pharmacy and referral management solution, among others. Earlier this month, the VA and the VA OIG released 3 reports highlighting issues with pharmacy and referral management, as well as how VA and Cerner are handling the issue ticketing process. While we were aware of most of the issues in these reports, I am extremely concerned by the fact that most of them remain unresolved. It has been a year and a half. We need to understand what's holding things up. Earlier this month, we held a roundtable discussion with leadership from the 3 medical centers. What I heard, loud and clear, is that the pharmacy solution does not meet their needs. It makes both the physicians' and pharmacists' jobs more difficult than it was in the legacy system and still requires a large number of extra steps and workarounds. Staff shared that they feel the shortcomings of the system introduce an unreasonable amount of risk in their patient care efforts and putting veterans' lives and health at risk. This was highlighted by an episode in Spokane Pharmacy that the Spokane Pharmacy Director brought to our attention, where a veteran's heart medication fell off his record, causing the veteran to run out of medication. I've heard that the veteran needed to be hospitalized after a cardiac episode. While I know that this issue is more complex than just an EHR failure, we have been concerned about something like this happening since I first joined the committee. This type of event is unacceptable, and I expect to hear from VA and Cerner today how they are going to prevent this from happening again. I also heard from the frontline staff about the shortcomings of a referral management system. The new workflows have added an enormous amount of extra work, which is dramatically affecting their productivity levels, and more importantly, their ability to get veterans access to necessary appointments. Access and wait times are a major issue of concern with VA, and this is not making it any better. Additionally, there seems to be major issues with the system's instability. We heard from Spokane that there have been a large number of system outages and degradations since their go-live 18 months ago. There have been issues with DEERS and Oracle databases that have taken the system down, among other things. It's hard to do your job when the systems you rely on aren't working. I also expect to hear from VA and Cerner today about what they are doing to improve system stability. Lastly, I've heard that VA has added Seattle, Ann Arbor, and other more complex VA facilities to schedule for this year. I am very cautious about this timeline. Given the issues that we are seeing in Spokane and Walla Walla, I think the risks exceed the benefits, and have seen no indication that the system is ready for the challenges at those facilities. These issues have to be fixed first. And the concerns of the facilities currently using the system needs to be addressed. Until these issues are resolved, the committee cannot support VA going live with Cerner at larger, more complex facilities. I appreciate that the VA and Cerner are here today to discuss their plans to address these critical challenges. With that, I would now like to recognize my colleague, Ranking Member Rosendale, to deliver any opening remarks he may have. Mr. Rosendale.
Thank you so much, Mr. Chair, and we are absolutely singing from the same sheet of music today. I wish today's hearing wasn't necessary. VA and Cerner should be spending 100% of their time fixing the persistent technical problems in the electronic health record that are driving staff to quit and putting veterans at risk. VA has acknowledged 26 of these problems. Many of them involve changing the Cerner software. However, there's been no concrete action to solve any of these. Even after admitting the problems exist, some VA and Cerner officials are still wishfully debating whether they will simply go away at other sites. There should be no more go-lives or additional funding until every single one of these has a fix. Secretary McDonough assured us that the Cerner system would not be introduced at additional facilities until it is fully functional at Mann Grandstaff in Spokane. And I am sorry that I will have to disagree with Dr. Adirna on what the definition of fully functional is. If VA and Cerner had taken action, we would not have to be here today. But we are talking about the same problems, again, that we've been discussing for the last year. Unfortunately, we had to bring VA witnesses in to testify to get some basic information. Staff have been asking for briefing on the plan to solve the 26 problems for over 2 months. The chairman, ranking member Bost, and I have sent letters to communicate our top priorities and concerns. In January, we asked the VA to explain how it is interpreting the sole source justification for Cerner's contract. There seems to be a pattern of refusing to compete work among other companies. In February, we urged the VA and Cerner to concentrate on fixing the technical problems in key areas of pharmacy, referrals, and the patient portal before implementing the EHR at Walla Walla, Columbus, or anywhere else. In March, we warned VA and Cerner not to sweep the demographic data corruption incident and the related downtime and shutdowns under the rug. Earlier this month, I implored VA and Cerner to fix the #1 pharmacy problem, the interface between PowerChart and medication manager retail. That is closely related to the issue of prescriptions dropping out of the EHR's active list after a year. This is creating more disruption and more patient safety risks than any other issue. We have not received any responses or, more importantly, seen any action on any of these letters. So, I will be repeating myself again today. I wish that it was not necessary. If we were seeing action, there wouldn't be any need for discussion. But this subcommittee's job is to ask these questions in a way that cannot be ignored. These problems with the system are serious, and they will not be ignored. And we will be on the record, and you will be on the record to make sure that we do get them resolved. Thank you, Mr. Chair, and I yield back.
Thank you, Mr. Takano. At this time, thank you, Mr. Rosendale. At this time, I recognize Chairman Takano for 5 minutes.
From the great state of California, not Montana.
Yes, sir. Yes.
Thank you, Chairman Mervan and Ranking Member Rosendale, for holding this very important hearing. I will keep my remarks short because I'm very interested in hearing from our witnesses today. And as I've said before in hearings on this topic, I've had misgivings about the sole source nature of the Cerner contract. And I continue to be concerned by the unresolved issues with the program. I realize that VA needs a modernized EHR. Continuing with VISTA is simply not sustainable in the long term. However, we must make sure that we're not putting undue burden on our frontline workers or endangering veterans in the process. We know that Spokane has struggled and continues to struggle to implement components of the system. There was a Sentinel event, which was at least in part related to the EHR. This has been one of my biggest fears from the very beginning. We must prioritize veteran safety at all costs. Now, I understand this is a completely new leadership team on the VA side and a new leader at Cerner as well. So I expect to hear how you're going to improve the program that you have inherited. We need to hear your plans for how to fix the program and move forward. Veterans and VA staff can't wait years for Cerner and VA to figure out the pharmacy issues. If those issues can't be resolved in these smaller facilities, I don't think you should be planning to move to larger facilities until a viable solution is in place. We need to address the valid concerns that have been repeatedly raised by frontline staff, the Inspector General, and Congress. VA staff have told us that they appreciate that we hear them, but they need action. I thank our witnesses for being here today, and I look forward to discussing solutions. Chairman Mervan, I yield back.
Thank you, Chairman Takano. I will now introduce the witnesses on our first panel. Dr. Terry EHRM is the Program Executive Director of the VA's Electronic Health Record Modernization Integration Office. She's accompanied today by Ms. Laura Puri-Atula, the Deputy Chief Information Officer for EHRM IO, and Dr. Donald Pura-Agliga, the former Acting Functional Champion. Also on the first panel is Mr. David Case, the Deputy Inspector General, VA's Office of the Inspector General. We will now hear the prepared statements from our panel members. I will remind you to please pause for 2 to 3 seconds before speaking so the recording will capture all of your words, and please remember to do so when answering members' questions. Thank you. Your written statements in full will be included in the hearing record without objection. Dr. EHRM, you are recognized for 5 minutes.
Thank you. Chairman Mervan, Ranking Member Rosendale, Chairman Takano, and other distinguished members, thank you for the opportunity to testify today in support of VA's initiative to modernize its electronic health record. Deputy Secretary Remy sends greetings from the Pacific Northwest, where he's visiting Man Grandstaff in Spokane and Jonathan M. Wainwright Memorial in Walla Walla. As you stated, Mr. Chairman, I'm accompanied by some of my current and former Electronic Health Record Modernization Integration Office leadership team, Ms. Laura Pura-Atula, Acting Deputy Chief Information Officer, and Dr. Don Pura-Agliga, VISN 16 Deputy Chief Medical Officer and former Acting Functional Champion. I want to assure you that I am committed to full transparency about our deployment efforts and to continuing to engage with you and your staff to ensure that we are successful. First and foremost, our veterans deserve the most up-to-date, world-class care, and to do that, VA healthcare personnel must have modern tools to deliver that care. This is the purpose of the transition from VA's legacy system to a new modern EHR. This enterprise-wide effort is one of the most complex clinical and business transformation endeavors in the department's history. Implementing a new EHR in any organization, no matter the size, is hard. But implementing one in a healthcare system as large and complex as VA is a tremendous challenge. We are transitioning from the current nearly 40-year-old EHR with 130 instances that longtime personnel are used to using to a new, single, state-of-the-art system that requires a different way for our personnel to do their work. I am sensitive to how hard this can be, having myself been through changes in EHRs. Despite our challenges, it is important to note that the EHR VA is deploying has been successfully implemented at more than 50% of the Department of Defense sites across the United States, with over 93,000 users. We have been applying lessons learned from the successful DoD rollout and from our initial operating capability, or as we say, IOC sites, to our planning for deployment across the entire VA enterprise. Since joining VA just 4 months ago, I have immersed myself in the program, and I am certain that we are doing the right things to properly position the program for success. My top 3 priorities include strengthening the program through our new management and governance structures, including ensuring we have in place leadership and staff with the right skills and experience to successfully execute our mission. 2, ensuring success of our early IOC deployment sites that are helping us identify areas for changes and to further refine our processes. And 3, planning and preparing for future deployments at scale across the enterprise. We applied what we learned at Mayo Grandstaff to improve our recent deployment effort at Jonathan M. Wainwright Memorial VA Medical Center in Walla Walla, Washington, which was a success. Site leadership have reported to us that the system is working as expected and staff morale is good. In 4 days, the EHR system will be deployed at VA Central Ohio Healthcare System in Columbus, Ohio. Lessons learned from the first 2 sites have been used to enhance every aspect of this next deployment, and Columbus staff are both eager and well prepared to transition to the new system. EHR implementations are much more than IT deployments. They are a significant transformation of healthcare delivery with people at the heart of adopting the new technology. The success of this new EHR depends on how well we train and support the people who use it. We have made great strides in both areas, and we intend to further improve based on end-user feedback. Frequent engagement with local site leadership and staff, VISN leadership and VHA leadership, along with abundant communication, are significant elements of our deployment strategy. We are actively monitoring system usage trends to gain insight into how adoption of the new technology is progressing and to identify areas where there may be concerns. In closing, although there have been challenges along the way, especially for Mayo Grandstaff as our first site, and there is more work to do, we acknowledge that, I am confident the program is on track to be successful. As Secretary McDonough has said, this is a leap forward that we can do and must get right. Chairman Mervan, Ranking Member Rosendale, and members of the subcommittee, thank you for the opportunity to testify today. My team and I are happy to respond to any questions you may have.
Thank you. Mr. Case, you are now recognized for 5 minutes.
Chairman Mervan, Ranking Member Rosendale, and Subcommittee members, thank you for the opportunity to discuss the Office of Inspector General's oversight of VA's Electronic Health Record Modernization Program. The OIG recognizes the complexity of converting VA's EHR for millions of veterans receiving VA care. Over the more than 2 years that we have observed employees at Mayo Grandstaff VA Medical Center and other VA locations, we have seen an unwavering commitment to this transition while continuing to prioritize patient care during the pandemic. When I appeared before this subcommittee in July 2021, the OIG had issued 5 reports examining EHRM. Our oversight in 2020 and through July of 2021 focused on VA's preparation for initial deployment. In addition to concerns about mitigations for productivity and the content and manner of VA employee training, we identified unreliable and significantly underestimated costs to upgrade the physical and IT infrastructure at VA facilities. Last year, VA confirmed it would conduct an independent cost estimate an assessment that will not be complete for several months to account for those resources. Today, only 14 of the 38 recommendations from these 5 reports are closed. Since last July, we issued 5 more reports. Last month, we released 3 reports about the experiences at Mann Grant staff. Clinical and administrative staff highlighted significant system and process limitations that raised questions about their ability to deliver quality patient care. We began 2 projects, one focused on medication management and one addressing patient care coordination. For the medication management report, we focused on 3 categories: data migration, medication orders, and medication reconciliation, and found numerous flaws. For example, poor data migration led to providers manually checking a veteran's list of medications and using workarounds, including manually re-entering prescriptions. Unfortunately, the concerns we expressed in April 2020 about medication management and a patient's ability to get timely prescription refills were borne out at Mann Grant staff. The second report addressed care coordination, the EHR functions that facilitate how care is synchronized between healthcare providers and directly with the patient. We found a range of problems, from scheduling primary care appointments and out-of-date personal information populating current records to laboratory orders disappearing. Among other significant findings, deficiencies in the referral function decreased providers' ability to manage a patient's referrals to other clinical services. We found certain system configurations, workflow errors, interoperability deficits, and insufficient training contributed to these problems. While working on these 2 reports, our healthcare inspectors identified continued issues with the help ticket process. We found a high degree of frustration amongst users. Cerner Help staff would close tickets without resolving the issues, and they would not communicate the ticket status to end users. These factors led staff to create unauthorized workarounds for the problems. When VA responded to the 3 reports last month, about 18 months after Mann Grant staff's go live, VA stated it had addressed only 8 of the 37 issues that remained unresolved after we completed our inspection in June 2021. Yesterday, we published an audit finding VA has not executed a reliable and comprehensive integrated master schedule. VA set standards for itself to design a schedule that is comprehensive, credible, well-constructed, and controlled. Although not every task for a 10-year project can be accounted for early on, there are strategies to create a schedule that can be tailored over time. We found that VA schedules did not meet these standards, which increases the risk of further delays, dropped activities, and budget overruns. In conclusion, OIG staff have repeatedly found VA's cost estimates and schedules unreliable and incomplete, a lack of transparency due to inadequate reporting to Congress, stovepipe governance that does not adequately engage VHA end users, and processes that do not respond to patient and end user concerns. The continued failure to implement these dozens of recommendations could lead to considerable cost escalations, delays in future deployments, and risk to patient safety and quality care. The OIG appreciates the resources and support Congress has provided to sustain our oversight. Chairman Mervin, this concludes my statement. I would be happy to answer any questions you or other members may have.
Thank you. We will now begin questioning for panel 1. As a reminder to my colleagues that members should pause 2 to 3 seconds before speaking so that all the members' questions are captured. I will now recognize myself for 5 minutes for questions. We have been talking about the issue with the pharmacy solution since before Spokane went live. The IG identified these issues as early as April of 2020. In fact, my staff heard many of these same concerns from the DoD personnel long before VA started implementing the system. I was disappointed to see that the IG report indicates that, after all this time, no resolution has occurred on most of the pharmacy issues. Dr. Adiram, in your testimony, you indicate that VA stakeholders have coordinated to resolve and close out 22 of the 37 substantiated allegations. Which of the issues have been resolved?
Great. Thank you, Chairman, for that question so that we can update the information that the IG provided to you. With regard to medication orders, we resolved six out of the 12 allegations since June 2021, as well as 6 out of the 7 under medication reconciliation. And then we're on course to resolve the others in May.
So 6 out of 12 on the medication and 6 out of 7 would be 12. Am I missing something how we got to the 22? Or those of the 20?
22 includes the other allegations in the other reports.
Okay.
Oh, sorry.
And for Mr. Case, has the IG seen any indication of these issues being resolved? If so, do you think these solutions will fix the medication management problems that staff has identified?
So far, the testimony today is 12 of 21 have been resolved. We have evidence only of 3 being resolved. Our process is that once matters are resolved in VA's consideration, they will send us evidence that, in fact, it's been resolved so we can consider whether it's been accurately and completely resolved. We have yet to receive that evidence, and we look forward to it. We also have a system in place where every 90 days we reach out to VA to ask for such evidence. So I look forward to seeing evidence of those 12, and then we will assess it.
This is, from my own learning experience, Mr. Case, what type of evidence and resolution are you looking for, and is there a process or a standard of operations that declares the time in which they declare that it is resolved till you receive the evidence? Because 90 days is a long time.
Yes, so we make the recommendation. They can resolve it at any time and simply provide us evidence. The 90 days is really a system for us to get back to it and say, where are you at? And have you resolved it? So they can send us information within 5 days, 10 days, it doesn't matter. We continue those 90-day reminders up until a year. At a year, under our semi-annual report to Congress, we have to indicate in that report what are still open in terms of recommendations. So the type of evidence is going to depend on what it is that the recommendation addresses. It doesn't have to be complete evidence, but enough to give us some certainty that the issue has been resolved and we can close the recommendation.
Dr. Adiram, can I ask what you expect as a standard operating procedure in order to get that evidence to the next level, timeline-wise?
I think, as the Deputy IG has said, it depends on what the issue is with regard to what evidence that they need to see. Some of the issues that are still unresolved, for example, includes issues that we've had with DEERS, which is the system of record for identifying information that is run by DoD. That's something that we're working with the Federal EHR Modernization Office, the firm, on getting to resolution. So that, how we resolve that may be different than some of the other pharmacy issue or medication management issues that have been brought up by the IG. Some of these can be resolved, for example, on ones that we're in the process of putting on contract now. One of them is being able to integrate the medication management retail into the power chart so that the person doing the prescribing can see the medication list at VA and can track medications, can also do refills and so on. We're in the process doing all the things that we need to do, the process to put that on contract so that we can get that issue resolved, and I believe that that probably would resolve some of the issues.
And I know I'm going over, Dr. Adiram. I just have to follow up because it's a continuity of the question. Most of these issues were identified a year or more ago. Why have they not been resolved yet? What is preventing you from fixing these issues? And my follow-up would be, how many of these issues require DoD concurrence?
Yeah, as I said, I've only been in the program for 4 months, so I can't really speak to what happened before new leadership arrived. And in fact, one of the first things that I did in coming to VA was to recruit an experienced program manager, which we've done. She's only been on board for the last 6 weeks. And that's an individual who understands contracting and how to work through program management issues. So these issues over the last few months that the new leadership team has been in place, we've been trying to understand what the issues are, what kind of resolutions they need. Some of them require longer-term close coordination with DoD, for example, because as you're aware, this is one instance for both departments. So the DEERS issue is one that we've mitigated, and Ms. Bertula probably could speak to how we've mitigated that particular issue. But some of the other ones may require other types of resolution that we're all working through right now. So maybe Ms. Bertula can explain the DEERS issue.
If we can come back to that.
Okay,
If we can put a
sure.
pin in that and come back to that. I've gone over my time. At this time, I'd like to recognize Mr. Rosendale for 5 minutes for questions.
Thank you, Mr. Chair. I find it very interesting when we started off this hearing that Dr. Deerham said that their 3 points of focus are strengthening the program, ensuring success at early sites, and planning and preparing for future sites. It sounds like we're trying to make sure that we continue to roll out this program. Where Mr. Case said that when he went to Grand Man staff, that he felt that the priority of the staff there was to prioritize patient care. And I hope that I am not the only person in this room that recognizes the huge difference in those two scenarios and priorities. Dr. Deerham, was there a Cerner system outage at Man Grandstaff in Walla Walla yesterday?
There was one today.
Unfortunately, yes, there was. But there was one yesterday as well.
No, sir, there was a slowdown over an hour. Ms. Bertula can explain to you what the two of them were, but there wasn't an outage yesterday.
Hey, good afternoon. There was an outage yesterday and today for 127 minutes, and it was a downtime based on some load balancers not being able to control the load.
Dr. Deerham, could you tell me how many outages have occurred since Cerner switchover with the EHR?
Ms. Bertula has the number. She can give that to you.
So I can take that for the record in terms of the exact number of the outages that have occurred, if you want to do that.
Well, I have on my record that there's been over 50 outages since the switchover. I don't have the exact time frame with which all of that has consumed, but it is certainly a lot of time when the physicians could not deliver care nor set appointments for the patients, and as you can imagine, was quite a disruption with the facility. Dr. Deerham, regarding the veteran who was hospitalized at Man Grandstaff after his or her heart medication lapsed, exactly when did the prescription drug drop off of the active list in the Cerner EHR, and how long was this individual without their medication?
Yes, thank you for allowing me to clarify that question, Congressman. First, I just have to say that as a physician, I'm reticent to speak about patients' personal, private information publicly. It is protected information, and so I would prefer not going into detail about this particular patient publicly. I'm happy to speak to you one-on-one about what I know about this incident, but I really don't feel that under HIPAA and privacy laws that I could speak specifics, but I can tell you that in general, all across the medical system, all prescriptions expire after a year. And there's a reason why they do that. The reason why they expire is so that the patient will see their physician and get updated labs or, to determine whether the medication is still working for that patient. Prescription, that's just a normal course. With regard to medications falling off the active medication list, that also is a usual thing that happens. It goes to the unactive list. With regard to Mayo Grand staff and the cutover and the migration of medications into the new system, it was done in 3 different ways to ensure that no medications got missed. The problem identified then, according to staff I've spoken to, because again, I wasn't at VA at the time, was that the concern was that there were duplicates, and this was creating an abundance of extra work in verifying the medications. So medications were verified 3 times prior to cutover and then post-cutover. Staff were trained to, and it was communicated to staff that at the next visit after cutover, they needed to refer to the Joint Legacy Viewer, which has information in it about a patient's past medical history. And so a practitioner should look
Okay,
within,
I'm
but
burning
just
up my
telling you.
time, so
Okay.
I've got to at least get one more question in
Sure.
here. Mr. Case, do you have copies of all the reports that the Inspector General produced there with you?
I do.
Okay, could you please turn to page 35 of the, let me see, this is Medication Management Deficiencies Report dated March 17th,
Yes, sir.
page 35.
I'm there.
Okay, and if you could go down to the second to the last paragraph, it starts off, facility staff stated that expired and discontinued medication information was not easily and readily viewable,
Yes, sir.
and pick up at staff's ability.
Yes, to view expired and discontinued medications was dependent on applying the correct user settings. As instructed by a facility leader, staff used Joint Longitudinal Viewer and the Legacy EHR when completing medication reconciliation to verify medication lists, a time-consuming workaround and one that increased the risk for human error in the selection of obsolete orders.
Thank you. Do you see a lot, as you were viewing this whole operation, a lot of areas where the staff was forced to create some kind of workaround in order to make this system work?
Yes, sir. That was the experience that we got concerns from the staff, and that's what these reports were based on in March. We looked to substantiate them, and some were not substantiated, but those that were often involved workarounds where they felt they had to adjust to the new EHR with their own system.
And in your own, or whoever prepared this report's own words, would that, in many of those cases, increase the risk for human error?
Yes, any type of workaround, that's the risk that you would have, is you increase the risk for human error.
Thank you. Thank you. Mr. Chair, I'm sorry for going over, but this is obviously some complex issues. Thank you. I yield back.
Thank you, Mr. Rosendale. At this time, I'd like to recognize Chairman Takano.
Thank you, Chairman Mervan. Dr. Darren, the committee continues to hear from staff and leadership in Spokane regarding their dissatisfaction with the new HR system. Whether it's the training provided or the difficulty it creates in providing care to patients, the common theme is that there are issues and the staff working with the new system don't feel their concerns are being taken seriously. Now that you've had a chance to review how the EHRM program is structured, how do you plan to address concerns regarding VA's ability to manage the Cerner contract?
Thank you, Mr. Chairman, for that question. I just want to assure you, we are listening to all of their concerns. But I also want to say, as a physician, none of us like our EHRs. It's just, a lot of clicking. And the other piece of this, too, is that people don't like to change how they do their work that they've been doing a certain way over a long period of time. That said, there definitely are issues that need to be addressed, issues that have been addressed, and issues that we continue to address. And one of the things that during the strategic review that was identified prior to our arrival was that the functional side, or VHA, and their clinicians need to be integrated into the program. There was a concern that that the issues brought up by clinicians were not sufficiently being listened to by the program management side. By putting the functional champion, the Office of the Functional Champion, under the Deputy Secretary within one organization, we're finding that that communication is much better. VHA is very engaged. This is probably the most engaged that they've been. We have governance structures in order to make decisions and to hear what the concerns are of VHA. And Dr. Paraglia is here virtually, and he is a deputy CMO, and perhaps if you want him to, he can speak to some of this if you'd like him to.
Well, maybe if we have a second round, I'd like to maybe go back to Dr. Paraglia to explain, to elaborate on what you're talking about, but I do want to get this other question in at least this first round. Regarding to the pharmacy issues, when do we expect to see real action taken to address the pharmacy issues?
Right. So we worked very closely with the Pharmacy Council and the pharmacy community to fully understand what specific issues they want to address and when. We want to be able to prioritize it based on their prioritization. So they identified 6 issues that they would like to see resolution. We added a 7th because there's CHAMP VA meds by mail that we feel there needs to be changes made to the system. Now, these are capability enhancements that are above and beyond the standard capability of this commercial off-the-shelf product. Therefore, it's going to take changes to the software. In order to do that, we've been working with Cerner to get these changes on their roadmap so that we can put it on contract and get them fixed. They have told us that it could be, depending on where it falls on their roadmap, anywhere from 13 to 36 months. I don't believe it's going to be 36 months. We need to get more clarity and narrow down when they can get these changes made. But
Just to clarify, you are
sure.
looking at an off-the-shelf product to be integrated? Is that what I hear?
No, we purchased a commercial off-the-shelf product. The changes that are being requested, that we need to do in order to help our pharmacy community and our providers are enhancements. They're additions to this product. So there's a standard product, and then we need to make changes through software changes. In order to do that, that takes longer than doing training or configuration change. So
this product
right.
is, the product you have that you've already purchased, it's not a Cerner product, it's a...
No, it is. Cerner is, I apologize, miscommunication. Cerner is a commercial off-the-shelf product. It's, you can purchase.
That's what,
right.
so when you talk
Right.
about commercial, you were referring
Yes.
to Cerner.
Yes.
Well, is there a possibility of using a third party at the table? Some other way to deal with this pharmacy benefit, the pharmacy issues outside
No,
of Cerner?
because the big one that we really would like to see done is by taking the part of the system that's called Medication Management Retail, or what we call MMR, and integrating that into the Millennium part of the EHR, the part that the provider uses. The MMR is used by pharmacy. So it's all part of the same Cerner system. We want to integrate that so that when somebody is writing an order and they want to see the medications that are being offered by mail, by VA, they can do that without having to leave the chart and go into the MMR section. So by integrating the two together, it makes it less work intensive for the pharmacist and the provider.
Well, you told me that they're estimating a 12 to 36 month development time for these changes to be made. We're talking about 2 Cerner products. And I asked you about has VA looked at a third party at all? I mean,
No, we have
so
not. This is all part of the same system. I'm sorry, again, I miscommunicated. These are 2 parts of the same software system.
Well, so that's why. Have you even looked at like going outside of Cerner? I mean, it sounds like you're planning to use the current Cerner contract vehicle to fix the issue. I'm asking, are you looking to go outside of that at all? Have you considered those options at all?
Right. So this is not really a fix. This is an enhancement to an already existing product, which is Cerner. We are tailoring the product to a VA requirement and how VA wants to deliver its health care.
Dr. Adjourn, I mean,
Yes.
at the risk of, so you're saying it's not a fix, but what I'm hearing from the Inspector General and what I'm hearing about what happened with this Sentinel event, which VA hasn't even acknowledged yet, is that there is an issue with the way that that existing prescriptions, can be renewed. There was somebody that did not get a prescription, a heart patient.
It was not, the EHR was working as it was intended to work.
So you're saying that to resolve the situation, you're calling that an enhancement, not a fix. You're not looking, VA is not looking at a third-party solution. You intend to use the current contract vehicle to enhance in a way that's going to.
That's a term of art in for EHRs. This is an additional capability to the system that we're adding, tailoring it to VA requirements. The EHR worked as intended. Prescriptions expire. It is up to the physician to renew the prescription when they see the patient.
Well, I hear you're shifting it to the physician and away the situation you're attributing to the physician's failure to. But I heard a very plausible sort of alternative view presented by the ranking member of the subcommittee that there were deficiencies that increased the likelihood of human error on the part of the physician. That they had to do a lot of workarounds. And so you're calling it an enhancement. I see there is a deficiency that needs to be fixed.
But we agree, this does need to be put on contract so that we can add this capability to the system. I agree with you. We want to reduce human error as much as possible using this tool to do that. I agree.
So you're going to use the current Cerner contract.
Yes.
You're not going to put out a new RFP to try to fix this. Have you even explored a third-party solution?
No, because again, this is internal to the existing capability. What we're doing is we want to have the part of the system, it's all the same system, integrated more fully with the provider part of the system so that the provider can see the pharmacy what medications are available, whether the medications have been mailed, be able to see whether it's, and again, to help mitigate a human factor, be able to see when a prescription may be up for renewal. So by integrating those 2 parts of the system, which will take what's called an IP change or a code change, we can reduce that kind of human factor issue.
Thank you, Dr. M. I've gone way over my time, but I appreciate your answer. I yield back.
At this time, I'd like to recognize Representative Newhouse.
Thank you, Chairman Mervan and Ranking Member Rosendale. I appreciate you very much allowing me to sit in on this important hearing. And just let me tell you, my presence is because I've heard of a lot of concerns about as the words I heard you use, Dr. Adiram, that veterans deserve first-class care. And my concerns are that some of my constituents and certainly some of the people that live in my state perhaps are having that ability compromised. And so obviously that got my attention. I appreciate the line of questioning that we've heard so far. But I wanted to talk to you a little bit about some of the data that the VA has provided about how the CERNA is performing in Walla Walla. So I appreciate you providing that update to us. So just go through some of that if I could. Last week, according to the data, primary care saw 41 new patients and 303 established patients. Can you tell me how that compares to a normal week before the Cerner electronic health record went live?
I don't have the data of go live, but what I can tell you is that as personnel are learning the system, it's expected that productivity will take a dip. That's something that we see in any go live, anywhere that a new EHR is being used. In fact, my colleague, Dr. Paraglia, has told me that it could be 3 to 6 months before you're back to pre-deployment productivity, and that's anywhere, in the commercial sector, DoD, or anywhere else. I will tell you what has been good news is that in speaking with the director there, they've really made great strides with coming back up in their productivity.
Could you tell me what percentage of normal that the pre-rollout patient load is the medical center is seeing now, and when do you think it would return to normal patient volumes?
Yeah, I couldn't give you that data. The medical center director perhaps can do that, but what I can tell you is that my colleague, Dr. Paraglia, tells me that typically it's 3 to 6 months.
Time. So let's look at the pharmacy side of things. According to your numbers, 3,294 prescriptions were refilled in Walla Walla just last week. Before Cerner, there were just under 20,000 refills in an average month. So obviously that works out to about 5,000 refills per week. Can you tell me what would account for the reduction in the prescription refills?
Are you referring to done through the portal, through the patient portal?
Just getting this from the updated information that you provided to us.
Yeah, I believe that you're talking about the refills that were done through the portal that the veterans use. The last numbers that I checked, about 1,700 veterans signed up for and are actively using the portal, My Healthy Vet. So there may be fewer veterans using that portal than were using the portal in the legacy system prior to go live. I know that the leadership is working with their local veterans to help them sign up for the portal so that they can use it.
So it seems that many of the departments in the center reduce their patient volumes to prepare for the Cerner's impact, probably anticipating just what you're talking about. As we've heard, there's been instances of compromised care, at least on one individual. To me, it doesn't seem like a pharmacy can afford to reduce their volumes. Veterans still need to get their medications. Can you tell me, in your estimation, how the pharmacy is doing in Walla Walla?
Mr. Newhouse, I believe the numbers that were cited in the report that was given to you are not reflective of the total number of prescriptions that are being done at the site. I don't have those numbers. We can get those for you.
Okay. Could you do that?
Yeah, well, we can do that.
So that we're comparing
Right.
apples to apples, so
right.
to speak.
Right.
Coming from the Yakima Valley, that's apropos. Can you tell me what extra resources the Walla Walla Pharmacy has been given to mitigate the problems with the pharmacy software from Cerna that we have seen in Spokane?
Sure. There may be additional resources needed with regard to personnel, especially at Go Live. What we did for Walla Walla at Go Live is that we increased the number of adoption coaches. Cerner provides adoption coaches. We've increased at the VISN, what's called the Clinical Resource Hub. They provided pharmacy support at the VISN level. Also, VHA at the central level also provided support to productivity, not just of the pharmacy, but also to behavioral health and primary care and so on. Did so both in person and virtually as well.
I know we're kind of following the precedent here of going over time a little bit, Chairman. Is that okay? Thank you. And I'm almost finished. So, Doctor, it seems to me it would be best to test how electronic records perform when the medical center returns to full capacity or normal patient volumes. In your estimation, would you say it's too early at this point to say, make a declaration that the process at Walla Walla is a success?
I don't think so. I agree with you that they may not be up to full number of patients. However, we did note on the first day of full operations, they were already talking about, the leadership there, about adding patients to the schedules. The staff there have been really fantastic. They've really adopted the record. This is not just qualitative assessment by the leadership there, but also the feature in Cerner Lights On. We are seeing a really good trend with the amount of time that the personnel are in the record has really gone down and is approaching what we see in the commercial sector. Good. So they're learning the system and they're doing a very good job. We're also seeing the number of patients that they're seeing increase. We're seeing the amount of time that patients have to wait to be seen go down. So all the trends are in the right direction.
I have heard, to be fair, that the folks at Walla Walla are very engaged in doing the best they can to make this work. And so I just want to say thank you, Mr. Chairman, for allowing me to be here. I would say that if we in the state of Washington have the distinction or the honor of being guinea pigs in this electronic records rollout, we just have to be certain that the issues that we have seen do not happen again in any other place in the country. And I got to tell you, Dr. Adhiram, what I heard today, I think this is probably, if not one of the most scathing IG reports I've ever heard. And it should be taken very, very seriously by you and everybody that works with you. If issues exist, obviously they do, and they haven't been addressed fully. We have got to be certain that we get this right in Spokane and in Walla Walla, and until we do, we should not do this, in my humble opinion, in any other location in the country. And with that, Mr. Chairman, thank you very much for allowing me to be here today.
Thank you. Next, I'd like to recognize Congresswoman Sherfelice McCormick for 5 minutes.
Thank you, Mr. Chair. This question is for Dr. EHRM. I noticed that in the fiscal year of 2023 budget request, that the VA requested less funding for staff in the programs office. After last year's fiscal request for 2022, including an expansion of 337 FTEs, and the fiscal year of 2023 request shrank then to 227 FTEs. Do you feel that there's enough staffing in the program office to manage all the issues and requirements for the deployment of this program?
Thank you, Congressman, for that question. The 23 request was based on the fact that we front-loaded, in the program, we front-loaded the infrastructure the IT infrastructure throughout the system, the improvements in the IT infrastructure. And so that we, whoever did the funding before we came on board, the budgeting before we came on board, that because a lot of the expense was front-loaded, that we needed less funding in the out years. We are, our level of federal FTEs is maxed at 305. We're at about a little over 200, I believe, and we're in the process of hiring those people that we need who have the right skills and experience. But we also have a support contract to help us through a lot of the pieces that we need to get done.
So do you believe that the EHRM is fully staffed up to handle the national scale deployments?
Are you? I'm sorry, I misunderstood. You're talking about the firm, the Federal EHR Modernization Office? That's not our office.
Okay, so well, do you believe that you guys are staffed up for deployment with the reduced number that shrank?
Yes, I do.
Okay, so my next question is about the training. The Tech Secretary's review of the program identified the need to extend training for frontline employees as an area of improvement. In response to the EHRM deployment, a sandbox training environment to mirror the production of their environment. What is the status of the implementation of the sandbox training environment?
Yeah, no, thank you for that question. And training is an area that we would like to see continued improvement. It has improved, especially since we came on board. We have moved a lot of the pieces of training from all in person. We now have virtual training. We do have a sandbox. And that sandbox is being used. I looked at the data. About 50% of people who are credentialed to use the sandbox use it, and they use it for hours at a time to practice their skills. One of the areas of improvement that I'd like to see for the sandbox are more case-based scenarios to help people benefit from the sandbox. Now, we don't use a sandbox in production, and the reason why we don't do that is because that could mess with patient records. So we have a sandbox that's not in production that people can use to practice.
And to what level does a sandbox actually mirror the actual environment?
I'm not sure I understand the question.
So to what level, like currently, how does it mirror? Does it mirror it precisely to the actual real environment, the sandbox training?
I'm not certain that it does, and we can take that question back and get you a clearer answer on that.
Okay, and what additional actions are being taken to ensure users are adequately trained for the new system prior to going live, if any?
Sure. A good number of changes have occurred, a lot of them even before the new leadership came on board. A lot of these included not just an improvement in the quality and the content, but also in how it's delivered. As I said, we do computer-based training as well as virtual training. But with regard to the content, there's a lot more options that train to how the personnel are doing their work. What we say is we're training them to their specific workflow. So those are some of the improvements that have already been made. But as I said, I very much would like us to take another look. We're looking into bringing in a consultant to evaluate the training as it is now so that we can look at what's the best in class out in the commercial sector to help us identify ways we can improve. And what I really want to know is what within the training most closely associated with successful adoption, and to also bring in adult learning principles into the training. So we do plan to continue to improve the training.
Thank you so much for your answers. Mr. Speaker, I yield back. Mr. Chair.
Thank you. At this time, I'd like to start round two, and I recognize myself for 5 minutes. Dr. EHRM, I'd like to come back to the pharmacy issue. How many fixes would require a contract modification?
There are 7 of them that we've identified with the pharmacy community.
Can you expand on those?
Sure, absolutely. So some of these include, and the primary one which I talked about, is that bi-directional view between the MMR and the power chart, or it's in Millennium. That's the first one. We also want to ensure that, that we have the capability to update the pharmacist edits so that the provider can see them. We also want to mitigate active and recently expired prescriptions from the legacy system into the new AHR, including renewals, refills, and that we can renew an order within the power chart, which is so that there are no duplicate prescriptions. That will synchronize the patient's record in the MMR and power chart, including keeping maintenance meds from falling off the active medication list when reaching the legal stop date, which is one of the issues that you cited, and this will help providers to know when a medication comes off the active list. Also, one of the things that you may call a workaround, but is an extra step for pharmacists, is that one of the changes we want to make is to allow pharmacy techs to process the refill request without having a pharmacist to verify it. And we want the EHR to allow VA staff to generate refill requests on active prescriptions, ones that are refillable, within the ordering workflow and power chart so that it can be appropriately routed. And then last but not least, as in our discussion that we had, the CHAMPS VA meds by mail, we want CHAMP VA beneficiaries to have prescriptions processed in meds by mail and dispensed through the CMOP. So those are the 7 changes that we are going to be putting on contract for changes within the system.
If I could, I've also been informed that the code redevelopment that VA has requested will take Cerner 2 to 3 years to develop. Is this an acceptable timeline, in your opinion?
They told us it would be 13 months to 36 months, but similar time frame. It does require development or IP changes, code changes. And the Cerner would have to put this on what's called their roadmap for development. The first thing that we would want to make sure is that they're not already making these changes. But if not, then we'd want to put it on that roadmap, and we would want them to do this tech insertion at a usual time where we do these type of changes and not done outside of the roadmap. So they probably can best answer the question for you about why it takes that long to do this kind of code change.
So, just as a point of clarity, have we requested, has this process began, or are we thinking about having them start this process?
No, we've already started the process. We've been having discussions with them. We've asked for their roadmap, which we have. We've begun the discussions to get a rough order of magnitude on the cost, because again, this is in addition to, this is an enhancement, so it will cost us money, and we would have to find offsets, which we will, because this is a priority for us. And then it needs to be put on contract. So the actual putting on contract hasn't happened yet, but the process to do that has already begun.
Mr. Case, if I could, your thoughts on that timeline and what that translates into?
Yes, well, that's a timeline, 13 months to 36 months. It's a long timeline. VA has to evaluate whether that's a sufficient timeline that they can live with in terms of future deployments. And they have to make that kind of judgment, and it is a long timeline, and if it's critical to deployments, then maybe there has to be other solutions found. But at this point, they haven't even started on the process yet, really.
Okay. is the point that I'm trying to make perfectly clear.
Yeah.
And are there any other alternative solutions that are available other than what we've talked about?
Not that I'm aware of, not now. I mean, off the top of my head, I couldn't tell you, but no.
Okay. At this time, I'd like to recognize Ranking Member Rosendale for 5 minutes.
Thank you, Mr. Chair. Mr. Case, your recent reports substantiate many problems with the EHR and conclude that if left unresolved, they will pose a risk for patient harm. How does your office define patient harm?
Yes, sir. When we look at patient harm, what we look at is impact to the veteran from the veteran's perspective. So patient harm can include if a veteran is seeing the VA for mental health concerns, is in a crisis, a delay in an appointment, even a short delay, can result in patient harm, especially from that veteran's perspective. Missed prescriptions. If you're getting insulin, if that's missed, that results in patient harm. So patient harm is viewed at, from when we look at reports, from the perspective of the veteran and the kind of care they're receiving, and are they receiving that care, and is there potential harm in what's being done.
And would you, is the recent cardiac incident at Mann Grandstaff, would you identify that as patient harm?
Well, we're going to start looking into that issue and identify exactly what happened and what the causalities were and what the results were. So I would be premature right now to try to answer that question.
Okay. Mr. Case, does the version of Cerner system that went live in Walla Walla generally carry the same unresolved issues as Mann Grandstaff, which are described in your reports, and do they pose the same risks of patient harm?
Well, I think we're going to find that out over the next 3 to 4 months, whether that's the case. What our experience was in Mann Grandstaff was that we did not start to hear really concerns from staff members until about 2 to 3 months from go live, especially as additional support started to pull back. And so I think to really assess that, we're not going to be able to assess it until we've seen more history at Walla Walla and the system is in place for another period of time. That exact period, I can't tell you, but it's certainly another 2 to 3 months, I would, if given the history we saw at Mann Grandstaff.
And when did you first report on the problems at Mann Grandstaff?
Yes, we started hearing about those problems about 3 to 4 months after go live, and then they accelerated, and we turned to basically compiling the concerns and that were expressed, then working to organize them, then to working to substantiate or not substantiate them. And so it's a process. There were a lot of concerns expressed that we had to organize. And so the process will depend in part on what we're hearing. Have we looked at before, the number of concerns expressed, but our intent is to address these kinds of issues as quickly as we can while being fair to the process. And
Sure, but these problems were first reported, when did you first report on these problems?
yes, we started reporting on issues with Mann Grandstaff really last summer when the training came out that it was really a problematic effort at training, that the staff did not feel well prepared, and we issued a report last summer on that. These more specific concerns on medication management and care coordination were coming out during that time, and then we turned to reports on those as well.
And do you know when Walla Walla and Columbus were originally scheduled to come online?
It was before now. I can't remember the historic timeline when they were scheduled to come online, but the rollout process has changed considerably, in part because of the stand down that the secretary used last into the spring and into the summer. And then there's been changes in how they're going to roll out. And so there's still much yet to be determined, but they rolled out later than were anticipated, at least in the original schedule.
And do you, have you received a new updated rollout schedule for facilities going forward?
We have received a schedule. We received that in December. I'm not sure if it's being modified, and we do hear of changes, and so we do have a schedule as of December. Now, whether that's going to be modified or not by VA, that's unknown, but we're preparing for additional rollouts to provide oversight to those.
And with the changes in the schedule and the information that you have not received, how is your anticipation of the impact on the actual budget that has been allowed for?
Yeah, the budget is a question that's very uncertain. We do not view there to be currently a reliable budget. Last summer, we had 2 reports that showed the life cycle cost estimates for physical upgrades and for IT upgrades were not reliable. And it requires that VA, and they've committed to do this, undertake an independent cost assessment. That will be done, but not done for several months. So that's, and then there is no integrated master schedule at this point. So we don't know exactly what VA's plans are and how they intend to implement their plans over the 10-year span. And it's more than just identifying dates on a calendar. They have to account for work that has to be done, whether it's infrastructure upgrades, IT, physical infrastructure, that training that has to be done. And they have to build in a risk assessment with a best case, a worst case, and a most likely case. And to date, that hasn't been done. And all that is going to impact budget and when the budget is, the amount they think they need and when they need it. And so at this point, it's hard for us to comment on budget because we just don't feel there's reliable work out there on it.
Thank you very much. Mr. Chair, I yield back.
With that, I recognize Chairman Takano.
Dr. Deeren, I'm the one member on this platform that remembers 4 years ago when this 10-year contract was, this sole source contract was announced by Dr. Shulkin. There are 6 years that remain on the contract. And from what I'm hearing today, you're saying that possibly 3 years to implement this code change that you're talking about. Did I hear that correctly?
Yes, you did, but I do want to say.
Excuse me,
okay,
so 3 years out of the remaining 6 years could be devoted to this code change, and we're talking about, I mean, the Inspector General just talked about VA is going to have to decide whether this code change, the timeline is acceptable. I just simply don't understand why I'm not hearing that VA is also looked at or at least explored outside solutions, that you're only looking at a solution that Cerner is telling you could take up to 3 years.
All right, so there's a lot to unpack there. There's a couple of issues with that. Number one, the enhancements that VA wants are specific to how VA delivers care. So it's not likely that there are solutions out there because that's how VA delivers care. This system, this EHR, everybody needs to recognize, is the same iteration that is being used across DoD successfully. So it is a safe system. It's just a different way that people deliver care. It is also being used in over 27,000 healthcare sites in the commercial sector. So I want to make sure that I level set here that this system is usable as it is. However, VA has decided that it wants to deliver care in a different way. And so we want to make these changes so that VA can continue to deliver care in the pharmacy area the way that it has been delivering care.
Well, you know, the committee has noted, my staff has noted that a request for information for the Program Management Office contract is now out for response from the industry. And given the performance of the program, I'm sincerely hope that you're not planning to take this competition lightly. And I've heard several accounts of scope creep and redundancy between the Cerner vehicle and the PMO contract, and my staff will be watching this process closely to ensure that VA is doing their part to deconflict the effort. Further, the contract vehicle that VA uses to award this contract should be reviewed to ensure that there is sufficient competition and that past performance is taken into account. Now, Dr. Durham, I realize that you are not the contracting officer for this. You are the program executive and an integral part, but you are an integral part to defining requirements and selection requirements. Can I get a commitment from you to ensure that you and your federal staff are engaged fully in this effort?
We are fully engaged in this effort, and I agree with you, Mr. Takano, that it's important that we get the right support contractor in place, and we have the same goals as you in getting that contractor in place.
All right, well, thank you. I yield back, Mr. Chairman.
At this time, I'd like to recognize Mr. Newhouse for a round of questions.
Thank you, Mr. Chairman, and thank you, Dr. Durham, for you being here and testifying. This is important, as you understand. I've come to learn that the Spokane Hospital Man Grandstaff has a budget deficit, and I also understand that two big causes of that are the fact that the EHR created significant additional staffing cost associated with that, and also reduced collections. You're aware of that? Do you know how much that budget deficit?
I don't know the answer to that. That would be under the purview of the Veterans Health Administration. But I did review data because of my concerns about Man Grandstaff and why they were not adopting the system as it should be adopted. I did review data of their productivity and patient safety prior to go live, and their productivity took a big dip in the month prior to go live. It was pretty low. It was well below the average for the health system, and that was during a time, if you recall, the Delta wave of COVID perhaps caused that particular dip. But if you're making a very large change to how you deliver healthcare during a time where your productivity has taken a hit at a site whose patient safety is below average, you might expect that this might be the outcome. So I share your concerns, but we provided personnel to help support some of these things. Cerner has been there to help with adoption. They haven't left. VHA, I understand, last summer sent a full team of patient safety personnel. And then when I first came on board, I directed a team to go out to Man Grandstaff to investigate and to speak with staff as well as leadership to get a really good on-the-ground look at what was going on there. And they held 16 different engagements, our team, to find out what were the things that were causing them their issues. And I agree, training was not good at the time that it was implemented at Man Grandstaff, and that's why there'd been a focus on improving that training. But it's more than training. As somebody who's gone through these deployments, it's really important that you provide support to that productivity during that time that people are trying to adopt the system. So I think there was a confluence of factors that led to the problems that are happening at Man Grandstaff. And we learned from that. We learned a lot from that and made changes to how we implemented at Walla Walla, which is why I believe we were successful there.
So just a follow-up to that, and thank you for your efforts there. The medical center is considering looking at cuts to close that deficit, and that could include reducing services, laying staff off. Just a question, is the VA, or why isn't the VA, the central office that is, or the EHRM program providing funds to help make up that deficit? That, to me, that would seem fair.
Yeah, that's really not an appropriate use of the funds for EHR deployment. That would be a really good question for VHA, since they run the healthcare system, and I'm sure they can provide you a much better answer than I can, because I don't run their health system. So,
And then if I could, Mr. Chairman, ask Dr. Paraglia a question. Doctor, I understand that Douglas McKee, Dr. McKee was selected to replace you as the functional champion on this program. In other words, he would be the top representative of the VHA. I also understand he resigned just a few days later. So just my question is, are you performing the job again, or is someone else taking that responsibility on?
Thank you for the question, Congressman. I am not performing that role at present.
Do you know who is?
I believe Dr. Adhiram is acting in the role.
Is that the case?
Right. We're actively interviewing for a new functional champion. In fact, yesterday we interviewed several candidates, so we believe we'll have somebody in place very soon. In the meantime, I made sure to fill out the leadership team within the Office of the Functional Champion. We have a Chief Medical Informatics Officer as well as a Chief Nursing Informatics Officer. So it'll be a very short amount of time that we're going to be without a functional champion.
So you're currently filling the gap there. You're not taking it all on yourself, plus your regular day job.
No, we have a team of people, but I have it. The one benefit is that I'm diving deep into a lot of these functional issues, which I think are important. And I am a physician, an emergency physician, so and we have plenty of clinical people who've been supporting and helping us. Solution experts as well as other clinical personnel have been helping us.
Okay, thank you very much. Thank you, Mr. Chairman. I yield back.
Thank you. At this time, I'd like to recognize Representative Sherfalus McCormick, please.
Thank you, Mr. Chairman. My question is for Dr. Adhiram. I want to thank you for going through all this. I know it may be difficult, and anytime you're adopting a new information system, it is a difficult time. I've been in healthcare. I was in healthcare for 15 years, and we had to go through this process. And I understand that when it comes to customization and adoption, just because those the application may work in other areas, it might not work in your area, especially because the VA serves a special role in healthcare. So it is going to be a difficult process, but I have a question about the pharmacy and the mental health. Now, we're hearing that the pharmacy and the mental health leaders ask you to stop the rollout right prior to the go live. Is this accurate?
I don't recall that anybody asked us to not go live.
Were there any concerns, especially when it came to pharmacy and the mental health?
I'm not aware of of anybody asking around the mental health, but we've been aware of the pharmacy concerns, yes.
Okay, and when it comes to the budget, were there concerns, because the VA plays such a special, customized role, was that taken in consideration when looking at the actual budget that was put in place?
That's a tough question. I believe that when at the start, and again, I wasn't here, and so I wasn't involved with the budget development, there were some issues that were taken into consideration with regard to the budget, but others, such as the pharmacy issues, were not. They were not part of the original part of the contract, and that's why it's an additional thing that needs to be added on. So
from your perspective, with the customization that's going on now, with everything that's going on with Cerner, do you believe that in the future it actually will be compatible to the needs of the VA so that the VA can actually function to their best capabilities?
I do, and I believe that we need to continue to move forward because with each implementation, we're learning more and more, and we'll just improve with each one. We're in the pilot state right now so that we can learn enough to get to that, what we like to call that core EHR, what that product is that we'll be able to take to scale and implement across waves. So the schedule that our Deputy IG mentioned that was published in December is part and parcel of this, learning. So we started, at least since I got here, at Walla Walla, which was a small site. We're going this weekend to Columbus, which is a medium site, and then we have the larger medical center sites later. So as we're learning, we are adding we are making changes in order to improve the processes for going live, improving our training, improving the support that we do at Go Live, as well as determining what other changes may be needed in the system, tailored to how VA wants to deliver its care. Now, most of the care that we deliver is healthcare. Healthcare is healthcare. So, right, we do primary care, we do mental health, we do all kinds of other things like other healthcare systems. But in those areas that are different, we do need to be mindful and respectful of that and ensure that we have that capability within this electronic health record.
Well, in the time period that it's going to take you to catch up and actually get to that place of where it's working well, there will be collateral damage, right, where you can't service everyone or to that extent. Do you feel that would be minimized because you have a timeline that it would actually, you'll be able to serve?
Yeah, I don't believe that this system, that there's any evidence that it has harmed any patients or that it will going forward. I think it's important that we have the processes in place to mitigate any problems that could come up due to human error. We need to make sure that we have training and support at Go Live so that people appropriately adopt the system and use it as it was intended to be used.
So your belief that it's mostly user error and not, there aren't concerns when it comes to safety?
I'm reticent about calling it user error. I think that if we get that right mix of training and change management activities. We're learning a lot actually from Columbus. They have a lot of really great ideas that we plan to take forward to ensure that we help our personnel learn how to use the system appropriately. I mean, I could give you examples that we plan to make as part of our package to help our personnel learn the system. So I think that going forward, we will have that EHR package in place. Now, one of the things I do want to mention is that medication management in any system is a known patient safety risk, whether you're doing pen or paper, and you know this as a healthcare professional, pen to paper or any EHR, it's a risk. And to that end, we're working very closely with VHA's National Center for Patient Safety. They send personnel to our deployment sites to support the patient safety staff and informaticists as we go live. We are also creating and have created a separate unit within the Office of the Functional Champion to work on patient safety issues and help us identify areas that we can strengthen and help our personnel use the system, continue to use it in a safe manner.
Mr. Chair, would you mind if I ask one more question, or?
Yes, please.
So this question is more about, are you tracking, I know you're tracking user errors, correct?
We're tracking trouble tickets. So if personnel have an issue and they put in a trouble ticket, we are tracking that. Same thing with patient safety reports. We track those as well.
So is there a distinction with those trouble tickets if it's user error or system incompatibility?
We do investigate each one, and there may be instances, I can't off the top of my head tell you, where somebody may not be using the system appropriately, and that may take some trainings or, for that individual or something else, but that we do categorize them based on how to ameliorate whatever that trouble is. But, the trouble ticket could also be things like I'm having trouble logging on, all the way to having an issue with being able to document in the chart. So each instance has a different solution.
Well, thank you. I just wanted to make sure that we would be able to identify if it's actually incompatibility with the
Absolutely.
system or if it's really more training that's necessary because of user error. Thank you, Mr. Chairman. I yield back.
Thank you. Now we'll move on to round 3. Mr. Case, Dr. Utterum indicated that she was not aware of any patient harm. Is there an OIG? Is the OIG aware of any?
The way we look at patient harm is different. I'm not sure how VA is identifying what constitutes harm, but the way we look at it is from the veterans basis. We have those same patient safety reports, and we're going to review those reports to look at whether there's been harm as we look at it. And we're also going to continue our oversight in this matter. And so I really can't address whether there's been harm or not as VA defines it. So all I can tell you is how we identify harm. We're going to review the patient safety reports. We're going to be alert to continued issues. And what our reports have tried to do is identify risk. And that's an important aspect of really mitigating the possibility of harm.
Thank you. Dr. Pergolia, do you think the lack of a dedicated functional champion is the best interest of the program's success or VHA's clinicians? What impacts do you think the lack of this position will have?
I believe the functional champion is a necessary part of the program office in order to move forward safely. As Dr. Adiram said, they're in the process of recruiting somebody, and they should have somebody on board soon. I would defer the rest of the response to that question to Dr. Adiram.
Doctor, if I can have a follow-up question. In this whole process, can you share with the committee as a functioning champion what recommendations you have made or you find most important?
I had made recommendations collectively with the group of subject matter experts from the Office of the Functional Champion with respect to the risks that we thought should be socialized with VHA leadership and further explored by the program office.
Can you identify one of those risks?
I have been out. I'm going to qualify my response by saying that I've been out of the program office since the 11th. And so I may not have all of the information most recent, but as per putting together that information, we made a recommendation to modify the deployment schedule.
In what way?
The recommendation was brought forward to modify the deployment schedule such that we would not go live at level 1 facilities, and we would go live at level 2 and level 3 facilities that were recognized as operationally and clinically efficient to safely sustain an implementation and deployment. Now, I would like to caveat that by saying that we did not say that the sky was falling. We recommended a pivot while we addressed some of the issues that you've raised in the line of questioning in this committee.
And prior to the 11th, did you receive information on what the decision was on the level 1 facilities?
No.
Doctor?
We are looking, because we are all new, we are looking at the schedule that we were handled in December to determine if there are any changes that are going to be needed based on whether or not it's safe and or efficient for us to go forward. There may be some changes to the schedule, but we need to look at all the factors. Now, Dr. Paraglia brought up a really good point, and one that the two of us had discussed prior to his going back to his real job, with regard to risk associated, the factors that are associated with a successful deployment. And so we've taken that to heart, and we are doing an assessment, an enterprise-wide assessment of all the rest of the sites, especially the major medical centers, looking at several factors, such as current productivity, where they lie on patient safety, the percent vacancy rate of nurses, primary care, and mental health, looking at the percent of their patients that get referred out to the network, and their leadership ready to lead. All of those things are being assessed for how we're going to do this, the schedule going forward. What we'd like to do is go VISN by VISN, and within the VISN, deploy first to the stronger sites so that they can pay it forward to those sites that perhaps are not, perhaps not as strong as the sites that go first. So we're looking at all of these issues, and Dr. Paraglia helped us with some of this because he, as a Deputy Chief Medical Officer of a VISN, he understands all of these issues and does these kind of analytics. So that's what we're in the process of doing before we complete a fuller deployment schedule.
Okay. I just wanted to emphasize that the functional champions recommendation is the same recommendation that we're making here. Right? When I had my opening remarks, I had stated that we want to make sure that before you move to level 1, that the system is working and functioning at a high safety level on the smaller levels, 2 and 3. So I'm just reiterating that fact. At this time, I'd like to have Ranking Member Rosendale.
Thank you, Mr. Chair. Dr. Deerham, I want to go back to the lack of a read and write interface between the power chart and MMR, as it certainly seems to be the #1 problem that we're facing or continue to hear about, and it is putting a lot of our veterans at risk, and I'm just very concerned about that. The VA seems to be waiting for Cerner to add this interface to its commercial product, but we're talking about a 36-month window here, and I can't understand why, after being 2 years into this process, why we're not making that a much larger priority.
Yeah, Mr. Rosendale, thank you for allowing me to clarify this. We are not waiting for them to make it as part of their commercial solution. We want to put it on contract and have it put on their roadmap for development. So that's #1. We're going to pay to have that done. #2, what it entails by not having it completed is that if I, as a provider, am in a Millennium writing orders, if I want to see or know where a prescription is, I either have to go into the MMR myself or call the pharmacy. That's the extra step. If a provider does that, then the system is used safely. It is much more convenient and easier to use if you have that bi-directional communication between the two parts of the system. And like you, we are eager to get this put on contract. If I could get them to do it tomorrow, I would love that. That would help us a lot. But we have
Again,
to,
but if we're 2 years, we are 2 years into this system, and it is like the biggest problem that we continue to hear about.
I hear you, but again, we're the new leadership team. We've only been here for a few months. So I agree with you. We would like to get this done as soon as we can possibly get it done.
Have you requested a dramatic extension of on-site support from Cerner going forward?
I'm not sure I understand what you mean by that.
Well, the OIG's report has identified, and it's my understanding that everyone has identified that some of the problems that are occurring is because the people that are trying to utilize the system are not comfortable with it, and if they are able to get additional training with support staff, that it seems to be resolving some of the problems. So I don't think that that's so complicated.
No.
Or have you requested on-site support from Cerner, additional on-site support from Cerner?
Right. Well, thank you for clarifying that. I don't believe that we need additional beyond what we already have contracted for support. What we do need to do is use the change management and other adoption activities that we have created that have worked for Walla Walla and are working for Columbus.
How long has Walla Walla been online?
A month.
A month, okay.
Right.
Mr. Case, do you think that based upon all the investigations that you did, that on-site training, additional staff from Cerner would be beneficial?
There's many ways to provide this on-site. Additional support, additional Cerner support is one way, and VA will have to consider that. Super users seem to be of great benefit in man-grant staff and seem to be well regarded by the staff there. That's another way. There's other kinds of support, but there does need to be extended support because, as Dr. Adiram and everyone has recognized, this is a change in the way the clinicians do business. And to do that, they need support. How that's done, VA is going to have to make some business judgments on how they want to do that.
Thank you. Mr. Chair, I yield back.
This time we recognize Chairman Takano for 5 minutes.
Thank you, Mr. Chairman. Dr. Durham, we've heard that there are funding shortfalls within Vision 20, which may, and I emphasize may, be related to the implementation of the EHR system in Spokane. And I've heard speculation about the capacity for inpatient care suffering some detriment as the result of the funding shortfall. Can you say anything to the funding issues in Vision 20, and have you heard about any potential reduction in services at man-grant staff as a result?
Yeah, Mr. Takano, unfortunately, I can't answer those questions. That would be up to the VHA to answer those, since they run the healthcare system and/or the Vision. To answer that for you, I would not. That's not something that's under my purview.
Okay. Well, I did hear you answer. I should have referenced the fact you did answer
All right.
in that manner to the question that was very similar, asked by another member. Well, I'm sure you're aware that the Cerner EHR system is not recovering costs at the rate of Vista, which could be increasing the funding issues going forward in Spokane. Can you comment about the cost recovery rates between Vista and Cerner EHR?
I'm not entirely certain what you mean by cost recovery rates. If what you mean by that is, are we saving money because we're shutting off the legacy system, or I'm sorry, I'm not clear on the question.
I'm talking, we're talking about third-party billing.
Oh, I see. Yeah, I can't answer that question. I think that perhaps we should take that question back. That may be for VHA to answer.
Okay, well.
We're happy to answer that, though.
Well, we're definitely interested in knowing
Sure.
The third-party billing.
Sure.
Cost recovery. We also know that the leadership in Spokane has mentioned hiring 400 employees to compensate for the productivity lost during Go Live. Do you foresee this to be an issue at sites going forward?
No, I don't. And I asked for clarification from the Vision director because Mr. Rosendale had mentioned that. That seemed rather excessive. I understand that based on requirements for EHR and COVID was how it was couched to me, that there were 200 personnel that were hired. But I can't verify that. That, again, would be a question for VHA.
Well, do you see a need for an increased funding and a dedicated budget line, not only to compensate for any overall funding shortfall, but to address increased staffing needs surrounding implementation of the Cerner system?
I don't, but as part of this, the pilot sites, that's something that we could and should be assessing to determine what other resource needs may be required as we change from the legacy system to the new system. I think that's a good point, but I don't see that there will be an excessive amount of requirements for that, but we'll be working with VHA on that issue.
Well, thank you. Thank you. In our July hearing with VA and the VA OIG, it was revealed that when issues from VHA were reported to the EHRM, They met with resistance from OEHRM leadership and were not included in the decision-making discussions. This specifically was referring to the inadequate training, and that was resulting in concerns for patient safety. Can you tell me what's been done since our last hearing to remedy this issue?
Sure. I think that's a great question, and I hate hearing that that was the case, because our stance in the program, at least from the new leadership, is that VHA is our customer. We're there to support them through this change in how they deliver care. To that end, I have gone to, since I've come on board, to all of their governance board meetings and their business meetings. I meet weekly with their acting undersecretary and acting deputy undersecretary. So at the leadership level, we are having we work together on these types of decisions, but they are also being made at the VISN level and the local leadership level. So at all levels throughout the organization, our program staff as well as our leadership are working in close coordination. I do know that decisions are made on how they want to deliver healthcare through their clinical communities, and that those are elevated up to the leadership of VHA, and then it's transmitted to program. So I think because, and it may be because I'm a physician and I've had relationships with many of these people from before, that we've been able to develop a very good working relationship and help VHA through their decision-making process on how they want to deliver care.
Well, thank you. Before I yield back, Mr. Case, has VA reported, changes back to you on this particular issue?
Yes, we're aware of the functional champion and its role, and we're currently involved in various oversight activities will allow us to gain an insight whether VHA really has a place at the table, so to speak, and is being listened to. And so that's one thing we always have in our mind, and it's an important consideration.
Thank you. I yield back, Mr. Chair.
Thank you, Mr. Takano. With there being no further questions, the first panel is excused. Thank you for your participation today. We will take a brief recess to reset the witness table.
Mr. Chairman, are you ready to?
I call this hearing back to order. On our second panel, we have with us retired Major General Patrick Sargent, the General Manager of Cerner Government Services. General Sargent is accompanied by Mr. Avi Vaswani, Vice President of Cerner Government Services, and Ms. Melissa Salido, Vice President and Chief Nursing Officer, Cerner Government Services. General Sargent, you are now recognized for 5 minutes.
Thank you, Chairman Marvan, Ranking Member Rosendale, distinguished members of the subcommittee. I appreciate the opportunity to participate in today's hearing and for your continued support in support of VA's Electronic Health Record Modernization Program. I look forward to getting to know and working with each of you. Today, I'm joined by two of Cerner Government Services' outstanding leaders, Ms. Melissa Salido, Vice President and Chief Nursing Officer, and Mr. Avi Aswani, Vice President, Program Manager, EHRM Program. Our country's foundational strength lies in the remarkable men and women who volunteer to serve and protect our freedoms. While making immense personal sacrifice, there is no population more deserving of competent, compassionate, and convenient care than they do. Our commitment at Cerner goes beyond deploying an IT system. The IT system is an enabler. Quality of care is the imperative. I hold this conviction that we have a once-in-a-lifetime opportunity before us, an opportunity to fundamentally transform the healthcare system we provide our veterans. Having studied and been witness to this subcommittee's important work, I know working together, we can profoundly change the way we deliver healthcare for generations to come. I had the honor and privilege to command the Combat Health System in Iraq, Carl R. Darnell Army Medical Center at Fort Hood, Texas, Regional Health Command Pacific, and the Enhanced Multi-Service Market in Hawaii during DOD's initial go-live at Madigan Army Medical Center, and served as the Deputy Commanding General of Operations for the Army's healthcare system. I have learned end users, many of whom you have spoken to, need to know that we are aware of their concerns and that we are invested in their success, and that we are here to help shoulder their goal to deliver quality care. The EHR should be an enabler. Together, the VA, Cerner, and our small, veteran, women-owned business partners, we continue to achieve historic milestones in VA and DOD's decades-long journey to provide a lifetime seamless care for service members, veterans, and their families. Today, Cerner solutions are used by 2 million users over 35 countries, which includes 95,000 users across VA, DOD, and the Coast Guard. These federal agencies are using a single common record to provide seamless care, and as the DOD implements Cerner solution at additional locations, we continue to gather lessons learned that will inform the future deployments. Most importantly, we have proven that the Cerner solution can be delivered at scale across the DOD. Together, VA and DOD are likely the largest EHR modernization initiative in American history. Under the leadership of Terry Durham, VA and Cerner, we have deepened and expanded our lines of communications, collaboration, ensuring unity of direction, action, and effort across the EHRM program. Additionally, the VA Deputy Secretary and our CEO on a regular basis demonstrating the commitment of senior leadership from both organizations to getting this right. In fact, they visited Man Grandstaff on yesterday and are at Walla Walla today, visiting with end users, staff, and VA beneficiaries. A few weeks ago, VA and Cerner delivered a successful go-live at Walla Walla, Washington, and we look forward to continuing the momentum to locations in Columbus, Ohio this weekend. From day one, providers and staff at Walla Walla showed proficiency using the system in only a few days into the go-live, and requested that Cerner training staff step back, knowing that the training support was there at the ready if needed. We also saw a healthy number of veterans who signed up for and used the new Veterans Patient Portal, exchange messages with the healthcare system, and to request prescription refills. Currently, there are over 31,000 veterans signed up for My VA Health. While we have focused on successful go-lives in '22, we will remain engaged with the VA providers and staff at the live sites. We gather real-time feedback and opportunities to improve their health care. To date, we have witnessed in the change orders of 3,300 change requests, including simplifying workflows, designs, and alerts. Improving the delivery of health care and the overall experience for veterans is a core of our mission at Cerner. We take the responsibility of caring for veterans, taxpayers, and our congressional stakeholders to heart. Candidly speaking, your questions may be uncomfortable. They challenge, and they rightly provide the appropriate congressional oversight to ensure a successful EHRM program. They will make us better. Mr. Chairman, Ranking Member Rosendale, I thank you for your time in the subcommittee and your staff for the fierce discussions and the transparency, sharing the concerns you have, and we're here today to listen to gain a clear understanding of your concerns. Thank you.
Thank you, General Sergeant. A reminder to my colleagues that members should pause 2 to 3 seconds before speaking so that all your questions can be captured or are captured. I will now recognize myself for 5 minutes for the questions. For General Sergeant, as I mentioned earlier, we've heard that there have been a large number of system outages and degradations at MAN Grand Staff since its go live in October of 2020. In fact, the system is currently not operational. What sort of root cause analysis has Cerner done to determine the cause of the system's instability?
Sir, I'm pleased to report that I got a text just moments ago that the system is back up from today's outage. As Mr. Rosendale discussed, it was an outage yesterday. Yesterday's outage pertained to a push we made to the system in the middle of the day, and they brought the system down. The one today, I'm not really sure. We're still doing the root cause analysis associated with it. As we continue to go through the process of the downtime, I'm pleased to report that there are downtime procedures that's being used to make sure there's a continuity of care it continues.
General Sergeant, can you define we made a push, what that means?
Yeah, there was an update to the system, to the IT system that was a normal update that was pushed during the day, and it caused the system to go down.
Will, if I could just follow up on that, was it determined that those updates will cause that again?
There's no validity in the fact that it would start again, sir, but we did have a technical issue with it going on yesterday.
Okay. What is Cerner doing to improve the system stability and reliability?
Well, I'll tell you what, I just got the phone earlier today with the president of CO Cerner Services, and we have made a determination that we need to do likely an independent look at our system just to make sure that we're not missing something with regards to the stability of the system. So we'll likely plan to do a technical review of the system to kind of make sure that we are doing everything properly.
where do VA and DoD fit into this? And I realize you don't have control over systems like VA Profile or DEERS. So what has VA done to expedite fixing timeout issues and interoperability with the vast number of IT programs that Cerner must interface with?
Take that one.
Thank you for the question. The VA and DoD have established a governance body to account for all the changes in the systems that impact our EHR system. That governance body provides the necessary oversight to evaluate the changes, to evaluate the test results in a non-production domain before they're pushed. The VA continues in partnership with Cerner to evaluate those changes and those impacts of those changes before they're put in.
You had talked about, General Sergeant, you had spoken that you were going to do a technical review and analysis. Is it feasible for us to be able to get part of that technical analysis to our staff to find out what might be causing that when that is completed?
Chairman, this is my 23rd day in the organization, and so I would have to get back to you with the processes to be able to understand internally how we go about doing that. But surely we will make some information available to kind of determine, you know, how we're going to go forward long-term with the subsequent updates to the system.
Is the current communication structure between your company and the contracting office and the OIT sufficient to expedite technical fixes?
I'll let our PM speak to that real quick.
Thank you. Yes, we are receiving the adequate support by way of necessary changes to support from the contracting officer side, contract changes, as well as any other necessary changes needed to support the system.
Okay. At this time, I will recognize Ranking Member Rosendale for 5 minutes.
Thank you, Mr. Chair. General Sergeant, I hear a lot of bragging about Walla Walla being so successful of a rollout, but isn't it true that they're only operating at about 20% of their patient load when they opened up?
So I'll let our Chief Nursing Officer kind of give some insight on that.
Thank you for the question. So initially, during the first week of go live, I can't offer you the exact percentage, but what I can share is that it was at a reduced capacity, which is completely normal for the first week of go live. I was actually on site at JMW for the go live, and I can tell you that I witnessed an actual improvement beyond that initial reduction that same week. And then they have continued to improve every week thereafter. And so,
Okay, but if we're starting at 20% of the patient load, I mean, we could do paper forms and number 2 pencils and handle that, quite frankly, okay? I'm not a physician and I'm not a pharmacist, but 20% of the load, and nobody here, and I really don't like it, whether it's Cerner or whether it's VA, everybody keeps avoiding this question. We have the numbers, just so you know. It's about 20% of what the patient load was. Okay, if you can't make that system run on 20% of your expected load, then you've got a real problem. So, is it true that you've got 790 go live tickets for the last month at Walla Walla? Whoever wants to take it.
I'll need to defer to VA for those exact numbers.
Well, I'll hold it up. It's 790, okay, tickets. And this is at the second facility because obviously we had a lot more than that when we were trying to get man grandstaff up and running. So you've got the second shot at this, trying to get it sorted out. And we've got 790 tickets in the last 30 days. And you're bragging about that? General Sergeant, does the schedule to deploy the EHR at every VA medical facility in the country by 2028 still hold up?
Sir, at this point, just as the previous Dr. Durham spoke, you know, a lot of that is being looked at and being adjusted. And so we will support the VA's reimagined schedule, and we will have the capability to support them going forward.
Did you just say reimagined schedule?
The schedule that they're reviewing right now, sir.
Okay. Does Cerner still contend that it can complete this project for no more than $10 billion, which is the current ceiling in your contract?
Well, when we look at predictability right now, as we said, it was an issue with COVID, then we had to stop. We will be able to support the VA schedule that they present to us, and right now, I don't know what that is.
Okay, but the schedule, we're not talking about the schedule now. Now we're talking about the actual budget, the $10 billion budget.
Yeah.
Is Cerner going to honor that $10 billion budget?
I'll let my PM talk to that one.
As General Sergeant said, there have been force majeure events that have impacted the cost trajectory of the program, including adding training facilities outside of the normal plan to enable social distancing protocols. The plan has been impacted. Now, we certainly can find opportunities to return to plan, but there have been unplanned costs that have been introduced due to things like force majeure events.
So we're going to take that as it's going to require an increase in the budget.
It will certainly depend, again, on our ability to replan and our ability to gain efficiencies. One way we have seen to gain efficiencies is similar to what we've seen in DoD, where they've not only taken one site live, not two sites live, they've also taken multiple sites live, multiple waves live, which create efficiencies in our deployment processes. If those efficiencies are able to return a cost benefit back to the VA, we would certainly be able to pass those on.
We're having difficulty getting one site live, no offense, but I don't see how in the world we're ever going to get 2, 3, multiple sites going live at the same time. Assuming that Cerner does not request any additional funding for the overruns, let's just say you find some efficiencies. Where would you propose that the VA obtain the additional funding to pay for the increases, which is $1.95 billion, that the Inspector General's report dated April 25th of 2022, titled the Electronic Health Record Modernization Program did not fully meet the standards for a high-quality, reliable schedule. So, if they reflect a $1.95 billion increase in VA's budget, if Cerner doesn't request anything additionally, where is the VA supposed to get that additional funding from that is a direct result of overruns of time by Cerner?
Cerner is not able to comment where VA finds the funding necessary to support requirements that are put on our contract. Cerner looks to fulfill those requirements and provide pricing to the VA to make the decisions, and the VA makes those trade-off decisions on whether those requirements should be supported or not.
So the VA is going to have to absorb the additional increase in budget from Cerner, and they're going to have to absorb the $1.95 billion that we've already identified of cost increases because of Cerner.
Again, I can't comment on what requirements VA will and will not fund.
Mr. Chair, I yield back.
Thank you, Ranking Member. General Sergeant, can you tell me what the total amount of downtime at Man Grandstaff since they went live?
I don't have the exact number committed to memory, sir, so I have to get that for the record. I just don't have that total number.
Okay. If we can get that, I'd appreciate it.
Yes, sir.
There are several issues where the Cerner Millennium System is not meeting VA's needs. Many of these issues were identified 18 months ago when Spokane first went live. Some of them were identified by DoD before VA even started the process, yet most of them remain unresolved. Can you discuss what is taking so long to fix these issues that staff have continually raised as having dramatic effects on their productivity and job satisfaction? Also, we have heard that VA has created an inventory of Cerner solutions that are functioning as originally developed by Cerner with some minor modifications and require major code development to meet VA needs. Can you discuss the items that require major code development and the status of that development?
So, sir, as discussed in the previous hearing, there are many VA unique requirements that are placed on the system that was not organic to it. And so I'll let Melissa kind of speak to that. She's been with the system for a long time.
Thank you, sir. So the example that I would give you for your specific question would be pharmacy, and that is a topic that we've been mentioning over the last couple of hours. So pharmacy is unique in the VA. They have what we would typically see in the commercial market for outpatient prescriptions would almost always be sent to a CVS or a Walgreens or your local city pharmacy, town pharmacy. In VA, they have a very extensive, successful system, which is their Consolidated Medication Outpatient Management, which is also known as CMOP. There are some unique things with CMOP that we are, as Dr. Adira mentioned, there are 6 items that we currently have alignment on what those requirements are, and we'll be accelerating those through the process.
What resources do VA or Cerner need in order to speed up the development?
So from a resource perspective, we need to just land on the requirements, which we have done. So we are in alignment on what the requirements are moving forward. We will continue to evaluate those in the short term until the funding is in place, just to make sure that if there are updates, based on our go lives at JMW and then our future one at Columbus. But we have been meeting with the council, the pharmacy council. We have been meeting with the local pharmacists who are using the system, with the physicians and providers that are using the system, as well as our national level folks as well. So with OHRM or EHRM, and others. So we are in alignment, and we have a plan forward.
Just to follow up on that, when you meet with the pharmacists who are engaged in the system, what are their major issues?
Their major issues are just some of the integration points, as we've talked about over the last couple of hours. So a lot of it is just the context of how things are viewed are different. And then there are some uniquenesses around the way that they do the outpatient pharmacy mailing. So again, we recognize that those are things that we do think are valid concerns, and therefore we do have a plan to address those moving forward. What I would say, Mr. Chairman, is that in the meantime, from a mitigation perspective, we have extensive training that is occurring to make sure that moving forward, including with JMW, they understand what those differences are from a contextual standpoint. So not only just enhancing training, but also meeting well in advance with the pharmacists and providers. So my clinical staff is actually on site 6 months to a year in advance. So we have pharmacists, nurses, and physicians that engage well before training ever begins, and we begin to have conversations around those lessons learned from Man Grant staff. That has yielded great benefit for JMW and then also at Columbus.
So we've heard over the last couple of hours that the redevelopment of the pharmacy solution to fix the major medication management issues will take 2 to 3 years. So I guess my very plain speaking question is, if you can spell out why that will take 2 to 3 years, and if it will be, is it a matter of staffing? Is it a matter of engineers? What is it a matter of? Because hopefully we all recognize that 2 to 3 years, there's still risk, and we're all here in order to reduce risk for patients. So in the most sensitive issues of the pharmacy, please walk me through that timeline and help me really grasp 36 months to code and to change that in order to have a fix to a risk factor of patient safety.
Yeah, I can take the question. Thank you, Chairman. So, and Avi can certainly add in his thoughts as well. So from a pure development standpoint, medication management is complex. We want to make sure that we are testing thoroughly, that we are not just testing the system, but also the end user experience, making sure that our user interface, that it's the ease of use is there. But we certainly want to make sure that everything that we're doing is thoroughly tested. And you're talking about, you know, a complex system with lots of medications. What I will tell you is that 36 months is really the worst case scenario. Again, we are aggressively evaluating that timeline. We do know out of the 6 what the priorities are, and we will work to accelerate those to a much quicker timeline.
Okay. Thank you. With that, I yield to Ranking Member Rosendale.
Thank you, Mr. Chair. Okay. Mr. Sargent, the OIG report identified lack of training as a key component to many of the problems for implementing the Cerner system. So what staff increases or trainers is Cerner prepared to provide to accommodate this?
Sir, as Melissa mentioned earlier, we go out to these sites 12 to 15 months in advance to gain clarity and consensus among the staff to determine why they're moving from one system to the new system. We bring out staff 11 weeks or more, 6 months out to be able to provide all the folks with a understanding of the system and the functionality and their role that they're going to use with the system. We provide enough staff for what the actual the clinical or the leadership of the hospital said they need and require. And so the functional champions, we have people standing over their shoulder as they're doing the training. And so I believe Cerner is able to provide all the training necessary to have each go live successful.
So, but we continue to hear that that's not the case, and the OIG's report says that that's not the case, and the on-the-ground information from Mayo Grand staff says that they had to bring on 400 additional FTE in order to accommodate the workarounds and the additional work that was generated by trying to implement this system. So how can you sit there and tell me that we don't need additional training when everyone else is saying we need training?
Lisa, you want to take that one?
Thank you for the question, sir. I can fully tell you that from a quantitative and qualitative standpoint, we have received feedback from our users at JMW that the training, that feedback that they provided from their first round of training, that we've made substantial progress. Is there still progress to be made? There absolutely is. But both JMW, which is Walla Walla, and Columbus went through an early set of training, provided robust feedback to us as well as Man Grant staff. We have taken that feedback, we have incorporated it into our training, and we are hearing that there is substantial improvement. Again, there's always room for improvement with any training activity. And as Mr. Sargent mentioned, we have engaged early and often clinicians on the ground prior to any formal training events to reinforce those areas where the system is vastly different than what they had in their legacy system. So again, pharmacy is one of those areas, referral management is one of those areas. We've put additional emphasis on that. We provide lunch and learn sessions with our providers and with our pharmacists and with our nurses. We spend a lot of time just doing extra elbow support. We attend their meetings, their management meetings, and they give us time on their calendar to have those discussions. So, yeah.
Okay. So when I start getting reports that we don't have adequate training, who are we supposed to be in contact with to make sure that those needs are filled?
You can contact myself.
Okay. So I'm glad you brought up the prescription because I have to continue to go back to this pharmacy issue. It is one of the most important issues. It's one of the most dangerous. We continue to hear the problems about it. Was the lack of an interface between the read and write, power chart, and MMR known by Cerner prior to entering into this contract?
Thank you for the question, Congressman. I'd just like to clarify, it's not an interface. It's actually integration between two systems on the same platform. So again, that's just,
Okay,
I just want to
that's
make,
fine.
because interface is very different. That means we'd be interfacing to a foreign system. I can tell you that as with any system, this is why we have an IOC period or a pilot period. There are going to be things that we recognize as part of that. So this is something that has been recognized, and that
Was it recognized before you entered into the agreement?
I would have to investigate that, sir, to give you the
Okay,
correct
because,
answer.
because to me, if a Cerner is holding themselves out as the professional in the industry to provide this service, that if you didn't know, you should have known. There's a lot of different precedent that is set, that things that you should have known, that you could have known. And when you enter into a contract of that magnitude, I don't understand, first of all, why you weren't even aware of it. But now we find ourselves where we are. And as Mr. Chair referenced, to be thinking that we were going to be 36 months with one of the biggest issue that we're facing, that we could potentially be facing it 5 years into the contract with you, it's very puzzling to me. I just have a hard time understanding that. General, I'm out of my time. All right. Let me get one. Okay, let me get one more here. General, will fixing any of the 26 key issues that we discussed on the first panel carry additional costs? And if so, who's going to be responsible for absorbing those?
Sir, to answer your question, I can't say what the additional cost is going to be until we receive the requirements. Dr. Adarm was saying that we're still working through the process to get the documents, and then we'll start the contraction discussions, and then we can tell you the cost at that point.
So the document was already prepared and provided to Cerner. Do we even know what date this was provided? Quite some time ago? Is it 30 days? Was it 60 days? Was it 90 days? I don't know if it's 90 days. Okay, so at least 60 days. So this list has been floating around for quite some time.
Sir, are you referring to the pharmacy list?
This is not just the pharmacy list, this is the total. It's the 26 key issues that were identified.
I think, as Mr. Sargent noted, having a list on paper is different than having a list in requirements. As soon as Cerner receives those requirements and can cross-reference those requirements against that list of 26, we'd be able to share with you what the cost impacts would be.
That's fine. Thank you.
Okay. The safety of our veterans is my #1 concern regarding the future of this program. If I don't feel that this is being taken seriously enough by VA or by your company, I will not support expanding this to larger, more complicated facilities. The risks to veterans' lives is too great, as evidenced by the report from this weekend. We will be sending a bipartisan letter to VA shortly expressing how seriously we are taking this. This issue is not partisan. Everyone on this committee cares about the lives and safety of veterans. General, I realize that you understand my concern and want to do the right thing. I would encourage you to continue to interact with our staff and highlight these issues as they arise so that we don't have to hear about them in the news. We have a responsibility as we modernize to not undo harm, not to do undue harm. Can you provide me with your plans going forward to ensure that we aren't having these discussions again? I know you can't promise zero patient issues, but I want your commitment to be open and transparent with Congress, who represent the veterans and who are affected by your program.
So, sir, I am all aligned with your comments. Having served 35 years in the Army Medical Department as a dust-off pilot, I have had the opportunity to see the evacuation of our soldiers off the battlefield. I've likewise ran a medical center in the United States. And we will not put patients at risk or veterans at risk with this EHR. I'm a beneficiary of the VA. I'm a beneficiary of Walter Reed Army Medical Center. And I can assure you that I will give you my commitment that we will work to have zero preventable harm, And we work closely with the VA, with all of our clinicians and staff to get that done. So you're asking me to make that commitment to you? I gladly do that, sir, absolutely.
Thank you, General. You done? Oh, at this time, I'd like to yield. I'm done with my questions. Okay. At this time, I would like to thank you for joining us today. And I'd like to just have my closing statement. Do you have a closing statement? Please feel free. I recognize Ranking Member Rosendale, who's going to give a little goodbye.
Look, you have maybe not this group, but you have been here before. You have heard these complaints before, and unfortunately, we just don't see resolution coming forward. And we are 5 years now, 5 years into this process, and I'm gravely concerned about the treatment of our veterans in these facilities because of records that are not being utilized or able to be utilized properly. We actually have data systems and we have information that shows that the doctors cannot rely upon the information that they are trying to use because it might have someone else's personal data on there. Now, if you're a physician and you cannot look at the information that you are supposed to utilize to diagnose a patient, to know that it's accurate and it's for the individual that you have before you, that is a major problem, okay? And that's just one of the things. The prescription drug issue, we have seen that come up time and time again, and now we have newspaper reports of someone who had a cardiac arrest as a direct result of not getting their medication, okay, at one of these facilities. Well, it's the main grant staff, so it's the first one that we're trying to implement. And I will not support the expansion of this system into other facilities until we have what Secretary McDonough assured us that we would have, which is a fully functional system at man grant staff. And we don't have that yet by anyone's reasonable definition. And so we appreciate you coming in and sharing information with us, but it just doesn't seem to be improving to the level where I feel comfortable allowing this to be utilized at any other facility. Thank you. I yield back.
I would like to thank the witnesses for being here today with us. I think it's clear that this program has a long way to go. I want to reemphasize that the subcommittee wants VA and Cerner to fix these issues as soon as possible. VA employees and veterans deserve nothing less. I look forward to continuing to work with all of you, ensuring that the VA has the resources and tools needed to get this important program right. In closing, our mission is the safety and the implementation of veteran health care. All of us take that very seriously, along with taxpayer dollars going into this. This system, as they say, cannot fail because what's on the other end of that is risk to people who had put their lives before others to protect our country. And we have promised world-class health care and benefits. So the delivery of the system and the emphasis and importance to make sure we get this right in a timely fashion is imperative as we deliver this system. So, General, I thank you for your commitment, your service to our country, and for this mission you have taken on to make sure this private sector entity finds an interface that could reduce patient risk and do all that we can to fix these issues as quickly and efficiently as we possibly can. I also want to emphasize the fact of the matter is that we are absolutely, positively making sure that you hear loud and clear that until these issues are corrected or on the path of correction, we have great concern for going forward for larger systems, and which would mean statistically greater risk. So ultimately, as we go forward, please hear those concerns, and I thank you for your time today, and look forward to seeing you again. With that, all members will have 5 legislative days to revise and extend their remarks and include extraneous materials. This hearing is now adjourned.